Thanks so much. Thank you so much for everyone that stuck around for the second to last talk in the last session. I'm an assistant professor at the University of Michigan. I'm going to be talking about some exciting new data that we're collecting. I have no disclosures. So usually we save limitations for kind of the end of our study, but I'm starting out with them because as we've seen in a lot of the studies that were presented, even in this session, one thing that can often hamper our ability to interpret them is that while we have great data about, the patient's age, their gender, their comorbidities, we often lack very basic information about the hernia. So, for example, when using large databases or even some existing clinical registries, we often don't know how big the hernia was. We don't know where it was located. Was it in the midline, in the epigastrium, not in the midline? And I think we try to account for that by saying this likely included the heterogeneous group of patients we normally see, so on the whole, it's probably accurate information. And we often account for some of these other surrogate measures to help us try to replicate that complexity. But I think it really gets to this idea that we're not always comparing apples to apples when we're doing studies in hernia repair, because as we know, a really small 2-centimeter umbilical hernia, or ventral hernia, might have the same diagnostic code as this very large hernia here on the right-hand side. So we've really been trying to tackle this mainly under the leadership of Dr. Tellem to really start to think about what are the other questions that we need to know to improve the care of this population of patients. Because as we've heard a bunch of times today, it's hundreds of thousands of patients, billions of dollars in healthcare use. And so really starting to understand some of these important questions about granular, clinically nuanced data about surgical technique. If mesh was used, what kind of mesh was it? How big was it? Where did we place it? And then again, some of these important issues about hernia size and location. And so to do that, we've partnered with the Michigan Surgical Quality Collaborative. You already heard Dr. Howard presenting some data from this collaborative earlier in this session. But essentially, it's a payer-funded QI collaborative, includes data from more than 70 hospitals, and collects data on patient characteristics, processes of care, and 30-day outcomes. But in January of 2020, so just over about a year and a half ago, there was a whole new section added, which is we're calling the MSQC Hernia Collaborative. And basically, we introduced a synoptic operative note to start collecting this data, and then had abstractors collect all of this clinically nuanced hernia-specific variables to give us start to allow us to develop, again, the very granular data that we would need to answer some of these questions. So this pretty busy slide, but it's just kind of a description of the exact variables that we're collecting, and you can see that there are these very granular things that are not typically available in existing registries. So the next few slides are pretty busy, and I apologize for that, but it's really just to give you a sense of, how we're looking at these hernias, the types of information we can glean for them, and then I'll kind of highlight some of the exciting variability that we're seeing. So you can see that we broke it down into 4 categories of hernia size based on the width. We're seeing differences in terms of the sex distribution, the age, comorbidities. Again, looking at location, you can see that we're getting really exciting information about where these are, whether people have had a previous hernia repair. Not surprisingly, a lot of the larger hernias you can see down there have had a prior hernia repair. And then again, this very busy, but really starting to show us, even within a 2-centimeter hernia, which I think we all think is probably the simplest of all hernias, we're seeing significant variation in the operative approach, whether mesh was used, where that mesh was placed, et cetera. And so I think apologize. So we also have 30-day outcomes right now, and we'll again obviously follow these patients longer to get long-term outcomes. But I think the purpose of showing this data is to really say, this for us right now is starting to be kind of hypothesis generating rather than explanatory. So again, a couple of things we found. So 14% of hernias less than 2 centimeters were repaired using the robot. We know that the use of robotics in hernia repair has really exploded recently without a proven improvement in patient outcomes, and particularly for these very small hernias, why is this occurring? Similarly, the 2-centimeter hernia, oddly, is a pretty controversial hernia, and it's pretty much a coin flip on whether you're going to get mesh for that type of hernia, and we know that there's significant short and long-term issues with mesh use. And then finally, again, not surprisingly, in the 30-day outcomes, we saw that there was a pretty linear correlation between complications and hernia size, which may help us better preoperatively optimize and counsel our patients that have these larger, more complex hernias. There's a few limitations. One, like I said, we're limited to 30-day outcomes, but we're still pretty early on in our data collection. I think every few months we're getting more data, so as time goes on, we're really going to get to extend that. And then there has been some missing data for patients, and our group has done a number of quality improvement initiatives to try to improve that data capture. But I think the important thing, and going forward, we're really excited about this is really the first non-voluntary population level data source that has this degree of clinical nuance. So when we look at other existing registries that have some of these same types of items, a lot of it's relying on surgeons to voluntarily input their cases, and so that may introduce some bias. But then also it's just really exciting because it's going to give us a new opportunity to focus on continuous quality improvement for surgeons and hospitals that take care of this large group of patients. Thank you.